Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show. Today, bringing you another really awesome guest involved in creating a better tomorrow for all of us. Today, we have the honor of being joined by Dr. Nigel McCracken, who is Chief Operating Officer of Virax Biolabs, which is an innovative diagnostics and detection biotech company. They're developing this really game-changing T-cell immunology technology platform to ultimately help provide early diagnosis for a variety of post-viral syndromes, indications associated with chronic inflammation, as well as T-cell exhaustion to help people better enable early treatment interventions. Dr. McCracken brings over 25 years of research and development experience in drug development within a number of indications, including oncology, as well as infectious diseases. Prior to Virax, Dr. McCracken was the chief scientific officer at BerGenBio, where he drove the plan for their companion diagnostics and assay development. Prior to that role, he served as chief operating officer of NuCana, a clinical stage biopharmaceutical company focused on improving treatment outcomes for patients with cancer. They are providing oversight for the operations of the business, R&D, execution of their corporate strategy. And he has additionally, over his career, spent a lot of time in major biopharma players, including Debiopharma, Shire, Nycomed, Abbott. Dr. McCracken obtained his master's degree in clinical pharmacology from King's College London, did his Ph.D. in biochemical toxicology from University of Newcastle upon Tyne, and his bachelor's in biochemistry and pharmacology from Strathclyde. We're honored to have him with us today. A lot of really interesting themes to get into today. Dr. Nigel McCracken, thank you so much for taking time to come on the show.
No, thank you, Ira, for inviting me. It's nice to be here.
Yeah, no, it's awesome having you. I'm really looking forward to this topic because it's extremely timely. But as we typically do on our show, I'd love to start things off by handing you the floor for a bit. Was reading through your background, looking at your history, reading a little bit about your Ph.D. in these extrahepatic tissues and how they deal with pesticides, which obviously led very nicely into your work with pharmacokinetics of inhaled corticosteroids and other things you've been involved in. Take a little time to tell us about yourself, because you've been on a quite interesting R&D journey yourself the last 25 years.
Thank you. Yes, no, as I said, I mean, I call myself more of a drug developer. As you said, just my background's biochemistry, pharmacology initially, and then the Ph.D. in drug metabolism. So, moving into the drug pharma business, I've always been interested to try and understand why people respond to drugs and why they don't. So when you think about pharmacokinetics, you're interested in what the body's doing to the actual drug itself, and from pharmacology, you're interested, from a drug point of view, of what the drug's doing to the body. So, right from the early get-go, I've always been interested in understanding the modes of action around diseases. And then basically, from if you're developing a drug, and you're looking at a specific target to treat that disease, just understanding the intricacies of that, because we're all different, and when we take a drug, it doesn't act in the same sort of way, and because we metabolize it and we break it down differently and whatever, and I guess over the years and as things have progressed, Initially, I was really focused on drug metabolism. I did my, back in the day after my PhD, when I did a postdoc, it was in pharmacogenetics. And the only pharmacogenetics you did was always related to enzymes related to drug metabolism, when obviously now that's completely exploded with all of the sequencing and the technology that is available to specifically sequence sort of people. So, from that point of view, drug metabolism, interested in concentration levels, because usually the concentration levels will it'll have an effect, a response. That response will have efficacy. It'll do what it's supposed to do, but it can also have safety problems. If you push it too hard, that every drug is toxic. Now, as the years went sort of past, I get really involved into biomarkers. And, as technology exploded, it wasn't biochemistry anymore, it was systems biology. So you understood that sort of complexity of the actual disease. And to that point, and this is where I get super interested, whether it was from an infectious disease point of view or from an oncology point of view, that the whole adaptive and innate immune system. Because the thing that intrigued me, specifically with oncology as well as infectious diseases, why do some people get an infection and some people don't? Mm-hmm. Why do people who maybe smoke 40 cigarettes a day or had done, and don't get any lung cancer, and some people who don't do? Now, I think ultimately the most effective way, that we get rid of, either viral or bacterial infections or even cancer is the body's own immune system, whether that be innate or adaptive, to get rid of that pathogen. And I think from that point of view, this is the thing that's really, really intrigued me. So the last 12 years, I've been more involved in that translational medicine, that translational development, where you're trying to understand multiple different things, whether they be specific mutations or whether it be the actual, concentrations, to try and understand why people, actually react, take a drug and it works specifically for them. Mm-hmm. Now, with that knowledge, and moving on, because obviously oncology, everything's around companion diagnostics. And the drug, I guess the way that the drug pharma has moved is, 20 years ago, you developed a drug, and if you're lucky, it maybe worked for 40% of the people. It's different now, because the regulatory people are asking you specifically to define the population to basically get those people, in the studies and whatever, and that's what you get approval on now. Now, moving on to that, that's where obviously the companion diagnostics came around, because you're stratifying your population. So I've always been involved in biomarkers, and I'm trying to understand biomarkers associated with disease or prognostic biomarkers. Now, moving on to the role I have at Virax, what you do realize, whether it's oncology or whether it's like a viral infection it's super important to diagnose early, specifically oncology, because once it gets too far, it's, with oncology, it's almost, there's a primary sort of mutation that's maybe driving something, and then after a while it almost branches out like a tree, and then it becomes a lot harder to treat, sort of thing. Same sort of thing with infectious disease, and we'll move on to this in this relation to around this T-cell exhaustion or chronic inflammation, which is associated with a number of post-viral syndromes, a number of specific diseases. And the question is does it get to a point, where your T cells are maybe exhausted, it's too far? And if it's too far, it's really, really hard to come back from it, sort of thing. And that's the same sort of thing with immuno-oncology as well. So I think this is where I was really intrigued, and was really, really super excited around that, looking at T cell exhaustion, looking to develop assays within sort of around to look at the T cell, to look at the adaptive immune system as a means to help with that early diagnosis and early sort of management treatment, and obviously, as you know now, although long COVID is something that is, front and present at this moment in time, people have been living with chronic fatigue syndrome and ME for the last 40 years without any diagnosis, and I think that's where the potential of where we would like to take, this T cell monitoring, these T cell assays, is got a real sort of potential to help with the diagnosis of things that just aren't getting diagnosed. And, usually when people actually, go to their general practitioner and stuff like that, it's usually about 5 or 6 iterations and a year later before they actually get diagnosed in something. And I think what we want to do is we understand that these things are complex, specifically long COVID and things like that. But we do believe there's most probably certainly a part of that we can potentially provide some early diagnosis to help, with those patients with those specific symptoms around chronic fatigue, that they can get some sort of treatment, whether that's some sort of help or diet. And certainly with long COVID, they're going to be developing compounds, in the future specifically around that.
Mm-hmm. Mm-hmm. And you mentioned you mentioned systems biology. You mentioned the complexity of this domain, and it's one that I sometimes look at and every now and then and say, wow, okay, we got our cytotoxic T cells, and we got our helper T cells, and our regulatory T cells, and our memory T cells, and needless to say, the T cell component of the adaptive immune response is getting more and more and more complex. And I would love to hear, sort of, before we get into everything that you're doing at Virax and with Virax Immune, talk a little bit about where you start in that extremely complex systems biology of T cells, and what sort of some of the core things we're looking to learn versus, okay, we'll put the innate immune response over there, but just the B cells alone, because we hear so much about B cells and antibodies lately the last couple of years, of course. Talk a little bit more about T cells while we have you on.
Yeah, you mentioned, okay, that starting right at the beginning, we know that we've got the innate immune system, we've got the adaptive immune system. Generally, the innate immune system just deals with some infections and stuff, and it sort of clears them up, sort of thing. When it has a problem, then it basically, what it tends to do is it takes pieces of whatever the virus or whatever or the bacterial antigens, as we call it, or basically it sort of triggers cytokines to specifically then kick in the adaptive immune system. And the adaptive immune system, we talk about, okay, these are lymphocytes, they're B cells, and they're T cells. Now, as you said, the B cells themselves, they're recognized for producing sort of antibodies, and they can do that without the help of T cells, or they can do that with the help of T cells. And with the help of T cells, as you mentioned, you have CD8, CD4 cells and CD8 cells. And as you mentioned, you have these helper cells, and the helper cells tend to help, with respect to, that antigen presentation and then the generation of those antibodies. And the B cells, the antibodies are there to sort of neutralize that sort of infection or that viral infection. Where that doesn't really work, the T cells then will come into play, because they're really there, the CD8 positive T cells, which are there specifically to, detect and then basically, kill the actual infection. And in doing so, they also release other cytokines that bring other things. So to your point, you are right. The immune system by itself is super complicated. And as I said, I spent an awful lot of time in oncology, and they talk about tumor microenvironments and stuff. It is super complicated. And please, I don't want you to think that Virax Biolabs has the answer to all of those. It's not. I think what we feel that is, with the current technology, say for instance, there's been an awful lot of long COVID studies and studies that have, and the usual thing to sort of that people use is they'll use your multiplex ELISA, which is great. Is usually have these big panels and whatever, 300, 400, cytokines. The problem is it provides good information, but it doesn't actually tell you what the source is coming from. Where that cytokine released, what type of cells, is it a B cell, is it a T cell? And so it's a little bit limited and a little bit sort of static. You also have flow cytometry again, but again, it has a little bit more problem around just understanding the complexity of that. Now, we're wanting to look at fluorospot. And fluorospot's been about for years, an early spot and fluorospot, and it gives you the ability, because you're looking at intracellular cellular cells or peripheral blood cells and stuff like that. So you've got the ability to look at T cells, B cells, macrophages. You can actually look to see where those, when you see that cytokine release, you can actually work out exactly where it's coming from. Is it coming from macrophages, T cells, B cells? So it gives you the ability to understand a little bit more about the immune response, to that viral or to that pathogenic insult. And that's where we potentially want to actually take this. So something around, say, long COVID and stuff like that, we would want to look at the cytokine releases specifically that are coming from these activated T cells. Now, where we're wanting to, what's super important for us is that, of course, it's super important to use a peptide mix within your assay that's specific to that actual virus. So in relation to the first, test we want to specifically is going to be, it's a SARS-CoV-2 specific peptide mix, which will be used to activate the T cells. And then we will look to track the specific cytokines that are, that are expressed and activated from that, and then start to then link that up to some of the symptoms that are associated with long COVID. Now, long COVID by itself, and I'm getting into long COVID just because it's very pertinent at this moment in time, because that a huge amount of people, certainly in the US and around the world, some people even say 30% of people who have SARS-CoV infection will or could actually get symptoms associated with that. So again, for us, trying to link up, those cytokines with some of those symptoms, specifically maybe around that T cell exhaustion, chronic inflammation and chronic fatigue, that's where we want to go. I mean, we know that the interesting thing about long COVID, it is self-diagnosing and it's complex. Mm-hmm. And there's lots of different symptoms, neurological, cardiological, metabolic, so of course, it's not going to do everything, but we feel that the post-viral syndromes that are associated with that, or the symptoms associated with that, around that chronic fatigue, I think we can certainly do something there. And I think this is where we're really excited around the ability to look at Fluorospot, which gives you the ability to look at different combinations of cytokines.
Yeah.
And it may well be a different ratio with a specific cutoffs. And because we're going to develop it in 96 well plates, you've got the ability to have different ratios of cytokines specifically in there. Now, there are usual suspects that are associated with the likes of long COVID and some of the post-viral. That's what we'll specifically look to do, work with key opinion leaders, experts within the field, and whether, because that's where the knowledge is, sort of thing. And we're just super excited to be able to do that.
Excellent. And continuing from that, because if one goes to the Virax Biolabs site, there's a nice flow chart on how all this ultimately works for physicians and their patients. So, there's a blood sample. There's obviously the Virax Biolabs Magic, an app that ultimately, I assume that, I'm on my app, I will, hey, I have a high interleukin-6, tumor necrosis factor alpha. I'm sorry, I'm trying to remember some of my immunology here, but it's going to give me a summary of something that will allow my practitioner to guide, hey, you need a TNF antibody, or you need some vitamins, or whatever I may need. Talk a little bit about how this is all going to work.
I think you're right. I think the initial... I think when we talk about these things, we ultimately, people are super involved or want to be involved in their own health. And certainly there's things that we can do, to reduce chronic or just to reduce inflammation. It doesn't need to be, taking a drug. It could be just what we eat, our lifestyle, whatever, and things like that. So I think when we talk about the app, we most probably need to sort of separate out a few things. I think there are things, and when we think about what we're going to develop for that app, I think it's going to be more around, dealing with chronic inflammation from the point of view of what we can do. We talk about, oxidative stress, or you can do things like what you eat, your lifestyle, maybe gets, you can do it, and we can monitor that sort of thing. I think the things that we're talking about in relation to things like long COVID or ME or other post-viral syndromes, say like Lyme disease and stuff, and Epstein-Barr and stuff like that, I think, what we'd want to do is more to provide a B2B sort of service where we would provide assays specifically that could be utilized by the healthcare, providers, whether they be general practitioners, whether they be health, or specific drug companies who are working specifically within that area. When you think about it from a long COVID point of view, because everything really has moved towards trying to, develop drugs to help with long COVID, because this isn't going to go away. It's almost like it's very similar to ME and to chronic fatigue syndrome. And I would imagine it'll go down that way sort of thing. And the interesting thing around ME, which I'm sure, long COVID is about, when you talk about it, we all actually live with these viruses that we just don't know about. So of, most of us have been exposed to, Epstein-Barr or something like, or herpes or something like that. The interesting thing is the fact that you've got this, if you've had this virus going about, and T cells and B cells, when we talk about the adaptive immune system, sometimes the body says, I actually can't deal with this without destroying my own tissues. And so, and in this instance, I'm going to keep this in track. I'm just going to keep it, at a level that's manageable. And this is where the sort of T cell exhaustion and chronic inflammation comes. And usually then what happens is when you get exposed to some other virus like SARS-CoV, then you're just floored. And I know people who actually have had that sort of thing. So I think, from our point of view, what we want to do is we want to try and provide diagnostics for early detection of post-viral syndromes. That includes long COVID, that includes ME, that includes, maybe lower hanging fruits like like Lyme disease and stuff and things like that, which are quite prevalent within the society, certainly within the US. And I think from that point of view, if we can do that, it's going to be super helpful to, the health providers and the healthcare system itself, because with that early diagnosis, because it's going to sort of take away that time either in hospital or going back to your general practitioner 6 times to try and find out what the problem is, sort of thing. And that's where we potentially want to take it.
Excellent. And as we're on this this topic of the T cell exhaustion, and you and I were chatting before the show. I'm sitting here in downtown Philadelphia. You spent a lot of time in Philadelphia when you were at Shire, and obviously down the street here is University of Pennsylvania, where one of the epicenters of all things CAR T cell nowadays. Spent some time on an episode with Bruce Levine. CAR T is quite interesting because obviously a holy grailish type of immuno-oncology platform, but they deal with the same issues in terms of, we cannot have reduced proliferation capacity, the impaired, you mentioned the tumor microenvironment is awash in all things T cell. Talk a little bit about how CAR T cell therapy and the strategies we use there can benefit from what we learned from Virax.
Yeah, I mean, as you said, I think in certain the hematological sort of indications, sort of thing, DLBCL, ALL, you've got approved, CAR T therapies. Initially, obviously, in its infancy, when it started, it was specifically related to the person. So the person, you take T cells out, you manipulate them, you put them back in. Then you have this whole GMP manufacturing, which is built up around these specific T cells, specific to the actual patient. So, they're built into the hospitals and whatever, as well as externally you have. And then obviously there's been a lot of sort of companies who have actually come up with the CAR T cells. Now, obviously, it's been super helpful for a lot of people, but in some instances it's not. We know that there's certainly safety, problems with cytokine storms and whatever, because ultimately, when you put the T cells in and you don't get the dose right, you can trigger it quite easily, and then the body can start attacking itself, and that's obviously what you don't want to do. The other thing is when you're with the CAR, it doesn't work for everybody. Now, the way that it is, at least the way that the CAR T has been in the past, it's usually once you relapse after first line and whatever, so you'll go through the normal sort of treatment from an oncological point of view and whatever, and then, second line, once you've had, you become refractory to you're relapsed, then you'll get CAR T if you're fit enough to specifically do that. And things have obviously moved on from there because the actual cost of CAR T therapy, because it's the individuals, is pretty high. So I think everybody's sort of moving to this allogenic off-the-shelf T cells. So, so it's, you're generating them more from some, general healthy population. Then so when you think about that, if you have something where you can look at the T cells, whether a person's T cells, whatever, to either give some help around how to dose, when I say how to dose, how much you dose T cell wise, as well as basically the frequency of that, to prevent the safety problems around the cytokine storm, which can be problematic now. In fairness, they are managing it, but it's still prevalent. Or is there a way that you could specifically look at the T cells of a patient following, that chemotherapy, or, to determine whether the CAR T therapy will actually be beneficial? And when I say beneficial, it doesn't work for everybody. The durability around that, and also you can get resistance built up. If there's a way of specifically helping with that, because if somebody's not going to benefit from it, they might actually benefit from something more. And wherever, and I think this is where we want to again work alongside people who are developing in there to see if there's a utility specifically to have a T cell based assay that you can actually develop in combination, almost like a companion diagnostic, to help with the actual sort of management and dosing of those patients. Now, again, T cells or CAR T is related to hematological. I know that it's always been a problem moving into the solid tumors, and I know there's a lot of stuff more around macrophages and NK cells, but it'll be super interesting to actually see, whether you can adapt that technology, because again, when you're working with PBMCs, you're working with the full gamut of macrophages, NKs, myeloid cells, the whole thing. It's not necessarily just T cells. And so I think that there's a real potential to work alongside the likes of Penn, because I know that they're super involved in T cell exhaustion, as well as immunology and whatever, and as well as drug companies who are specifically working within that area.
And Nigel, while we have you, I just have to ask, because obviously you're heavily focused on you mentioned some of these different infections, obviously SARS-CoV and Lyme disease, chronic fatigue syndrome, things of this nature. A very interesting topic for us the last couple of years has been sort of this general area of aging, and sort of the it's called different things, inflammaging, or T cell exhaustion from the perspective of just time, putting aside the infections. It's a little triad, and now we're seeing all these interesting connections. Is there a potential link between herpes simplex virus and early onset dementias and all that? Say a few words about aging, if you would, because clearly, it's not the core focus of what you're doing now, but clearly that triad of viral infection, inflammation.
And I think, to your point, and I've looked at I've watched the same sort of, I've watched the same sort of programs and blue zones and stuff, and I find it super interesting when you look at different sort of populations all over the world, and you start to look to see where, what are they doing differently? So there's a few things, the light exercise, a good diet, and whatever, things like that. I think that, and it goes back to what we're talking about, the mobile app sort of thing, that you would love to sort of, because people are super interested in that. And I know certain parts of the US, they like to sort of drink their sort of kale drinks and stuff, and their antioxidants and stuff. And I think that has a potential role, in what we were talking about right at the beginning. When you think about oxidative stress or reactive oxygen species, right? As you age, you get more. And if you can keep these things in track, whatever, and as I keep them to a level sort of thing, which is sort of manageable, it will certainly help. So when you go back to these people who live in these blue zones, they've generally got sort of, Mediterranean diets and stuff and things like that. They've got some light exercise, the community and stuff and things like that. I think that there's things that we can do ourselves without having to, take specific medications and whatever, Now, going back to the app, if, for instance, we were looking at to develop, a T-cell based assay, which was more linked to something like oxidative, or chronic inflammation or associated with, say, oxidative stress, then that might be something that you could and everybody talks about the microbiome, right? And because I'm sure a lot of the reasons why some people respond to things better, infection, is because maybe the microbiome is more healthy. Now there's things that we can do associate, and there's a lot of links between the microbiome and basically the immune response or the immune system sort of thing. So I am again super excited, and I know you're speaking to me, but our clinical scientific officer, Thomas, is he's super into longevity. And he certainly worked within that area, and certainly that is something that we want to, develop. We don't want to run into troubles, and that's why at the beginning we were talking about the app. I didn't want to, you run into a little bit of problems with, when you're providing sort of IVDs and for specific diagnostic. Not that you can't and whatever, but something like that, something with respect to your health, your well-being, your oxidative stress and stuff, I think you could do something major about that. And if you can inform people, and I think every person's different. So, to check your cytokine releases, and it's going to be complete. This is where you most probably need longitudinal samples, and you're basically sort of, over time, where you can see that you're affecting that and whatever, and it will help with your longevity and your well-being, assuming you can be completely unlucky and whatever, and come up. But all being well, I think, people are more involved and want to be more involved, in their health and generally sort of, now, the thing, I'm from Scotland and whatever, and Scotland was always known sort of, for being the heart capital, the heart attack capital of the world, sort of thing, or whatever, but obviously the diets have changed, and it's made a huge difference to people, and whether they're all getting taller and stuff like that. But I think we can really have an effect here. So the app side of things, and able to provide information to people along with some sort of relevant tests to help, I think is definitely the way to go. And I know that there are, healthcare providers that do provide certain things to try and sort of help with that healthy sort of style. But I think, it's definitely something, that, it's certainly worth doing, and certainly something that we'll be specifically looking at and looking into a bit more around that sort of oxidative stress and related to inflammation sort of thing.
Yeah, I like the way you weave the microbiome back in there, because obviously this feeds perfectly with sort of your background in pharmacogenomics, toxicogenomics. That yes, we are so very different, and if we can have that data, we can make the right decisions. So no, this is all spot on. I'm excited for you and what's coming next. That being said, what is coming next? We're almost at 2024. I know you got a bunch of things in the pipeline, but anything that I missed, anything that's coming up that you want to mention as we go into 2024, conferences, talks, places that we may run into you and meet you in the network at some point, please.
We were talking about it. I think there's diagnostic companies, who provide, diagnostics research use only and whatever, and they're great because, drug companies like to utilize these things to try and understand, whether they're trying to develop combined diagnostics. I think where we see, because it's T cells and immune cells, we have to be working with the key opinion leaders, the leaders within these specific, whether it's long COVID, whether it's ME or CAR T, we want to be working closely with them. So you can imagine it's for credibility, because look, I'm a scientist and I have the, you've got to sort of get out there. You need to be at the conferences. You need to be, sort of publishing and showing exactly, why should we be looking at Fluorospot? What can we gain from that, rather than doing, a whole site-off panel where we're looking at the whole thing, or we're sequencing everything, sort of thing. That's going to be super important for us to do. And what we want to do and what we are doing is we're collaborating with people who are still doing long COVID studies. I'm using long COVID as an example of a post-viral syndrome. But what we're going to want to do is to work with, the PBMC samples, because, and we're going to want to develop exactly what that cytokines, what the relevant cytokines, what the cutoffs are. And then as part of that IVD, because we don't want to just be research only. What we want to do is to develop an in vitro diagnostic that is approved, is FDA approved, it's approved, say, in the UK, sort of thing, that healthcare providers can use specifically to help diagnose it early, and in doing so. Now, it's going to be super important to get that information out there. And I would love to, and there are platform studies, certainly in the US, the React. I was just at a workshop, run by the European Medical Union, sort of thing, where the people from the FDA were there. So there are these big studies where people are really super interested, in understanding either how to treat, how to diagnose, certainly long COVID. So we want to get, right in the in the midst, get on those platforms. We're certainly identified a couple in the UK, and get that data out there, because it is a process. As I said, yeah, of course we can put our research only, but you can't make decisions off it. And that's not what we want to do. We feel that we have something that is going to have some utility here. Of course, it's not going to answer everything. There's no way it's going to, because it's just a super complicated. But certainly what we want to do is we want to be placed that when that information comes out and whatever, and it's people start to really understand the complexity of it, you're there and you're situated sort of thing with, the ability to get that diagnostic out there. We believe that we've got something of value now around T-cell exhaustion and chronic inflammation, those symptoms around the chronic fatigue. And then what we'll look to do is then develop that further as that disease knowledge sort of, grows within these indications and specifically. But, looking, right out there, could you, when you start to look into these post-viral syndromes, is there a commonality? Is there a commonality that, around T-cell exhaustion and chronic inflammation, which is quite similar from ME to long COVID to whatever? And, and all you need to do is you need to come at it from a specific peptide mix that activates it, rather than just looking at ubiquitously, and in that instance, could you provide something, a service specifically to do that, to really pinpoint, where the problem is. And pinpointing, if you can understand, what the, whether you've got CD8 positive T cells and stuff like that circulating around, or whether you're high, cytokine levels of this stuff, I think you could most probably help even with the potential, of coming up with therapeutics as well, sort of thing. And I think, going back to ME or chronic fatigue syndrome, I've had, relatives who've been living with it for 40 years and there's nothing, what you don't want to do, you don't want long COVIDs to be like that as well, because it's not going away. It might not be as deadly as it was before because it's not so pulmonary and it's moved up, but it's still causing problems. And these problems that people have are debilitating. They can't work, they can't get out of bed. I mean, it's terrible both for them, but both for society. So there's a huge need. And, going back to that early detection, I think, that's why I'm just super excited. And I've been doing drug development all my life. And what you realize is, I can develop a drug, but early detection is the way to go. And I think that's where it sort of comes together.
Yeah, that all important intersection of infectious disease, immune response, these inflammatory disorders, and then, as you were just mentioning, at the end of the day, what is the? I mean, this is really personalized medicine on
Yeah.
steroids, right? I mean, in some
Yeah, yeah,
extremely
it is.
major areas of unmet medical needs. So, I mean, yeah, I'm excited for you, and a big fan and rooting you on, because I'm
Yeah, no,
want to
I mean,
stay.
I don't know about you, but I mean, I'm one of these people, I sometimes I pinch myself. I love doing what I do, because you don't need to get up in the morning sort of thing, because, it's challenging. If it was that, it would just be boring. But
Right.
it's not. And you know that you've got the potential for making a difference. So I just, it's a sheer pleasure actually sort of working with industry, and working with, physicians and key opinion leaders and whatever, and brainstorming to come together to, come up with a solution to help people, whatever, and that's the fundamental of what Virax Biolabs is all about, specifically in relation to, where we want to take Virax Immune.
Awesome. Really awesome. Going to look forward to continue to follow you, Nigel, and follow the company's success. For everybody that is going to be listening to this particular episode of our show across the various podcast networks, or watching on our YouTube channel, again, you've been listening to Dr. Nigel McCracken, Chief Operating Officer of Virax Biolabs. We'll put the link to the company in the show notes so everyone can explore what you're up to. But Nigel, I really want to thank you for taking the time out of your schedule to come talk to us for a little bit about you, about what you're up to now and where you're taking the company. Obviously, thank you for what you do. And as we like to say here on our show, thanks for helping to create a better tomorrow for so many patients out there via what you're developing. It's a really awesome story.
Thank you, Ira. It's been an absolute pleasure. And again, thank you very much for the ability to actually come and speak to yourself as well as to your listeners.
Great having you.